While the original devices that gave us end expiratory gases from our patients were capnometers, they gave us a very useful number for end tidal CO2. That really isn't enough in the modern world. These days we have a clinical graphical waveform on all of our patients who are exhaling CO2 in the operating room and in the ICU. This is known as capnography, and you need to be able to assess the capnograph and make diagnosis from abnormalities in the traces. That's what you'll learn from this tutorial. Fundamentals of Anesthesiology and Critical Care with me, Pat Nelligan. Monitoring gases and vapors. Monitoring carbon dioxide. Part 2, CO2 analysis and capnography. Welcome back. In the previous tutorial, we discussed monitoring carbon dioxide, the CO2 content of expired gas, the end tidal CO2. I discussed capnometry, how it's performed and what it means, and what happens that causes an increase or decrease in the end tidal CO2. In this tutorial, we're going to look at the alternative ways of measuring CO2 in expired gas, and they are sidestream gas analysis, microstream CO2 analysis, capnography, and the capnograph after intubation. It's important to remember that we use end tidal CO2 monitoring all the time in our practice. It's mandatory in patients undergoing general anesthesia, and I think it should be used in all situations where an artificial airway is placed in an unconscious or apneic patient, and probably in the majority of patients that require moderate to deep sedation. In addition to just measuring end tidal CO2, there is tremendous value to performing waveform analysis, because looking at the CO2 waveform both in inspiration and in expiration, we can diagnose a whole host of circulatory and airway problems. And CO2 waveforms are generated by all devices that are plugged into monitors these days that measure CO2. They are the mainstream devices that I've already discussed, the inline devices, sidestream devices, and microstream devices. Let's start the discussion with sidestream CO2 analysis. We previously discussed mainstream CO2 analyzers, which are terrific in intubated patients and provide instantaneous information, but add significant weight near the endotracheal tube. So they're not great in the ICU, they're not great in prone or other awkward positions, and can only be used with invasive airway devices and don't measure other airway gases. As a consequence, sidestream CO2 monitoring was developed and rapidly became the standard approach in the operating room. In this system, a continuous sample of gas is taken from the breathing system, usually via an attachment built into the heat and moisture exchanger. Because expired gas is humid and will condense in the machine, the sample tubing contains Naflon that removes water, and a water trap called the defend on the GE machine is used to catch condensed droplets. Once inside the analyzer, infrared spectroscopy is applied across a range of frequencies, and light absorption is measured by the photodetector. Light absorption is proportional to the partial pressure of the CO2 gas or the other gas that's been measured, and then the monitor displays the data on the screen. Now, when I say other gases measured, the great thing about sidestream monitoring is that you can measure pretty much anything. And of course, in anesthesia, that means carbon dioxide, nitrous oxide, or any of the volatile agents. Carbon dioxide and nitrous oxide absorb infrared light in the 4 to 5.5 micrometer range. Volatile agents absorb light at much longer wavelengths, around 8 micrometers. On the monitor, carbon dioxide is displayed numerically on inspiration and expiration, and those numbers are referenced as partial pressures in millimeters of mercury or kilopascals. The other gases that are measured, oxygen, nitrous oxide, and volatile agents, Nitrogen is usually not measured, it's subtracted, but all of those other gases are displayed as percentages. This is convention, and conversion from partial pressure to percentage is performed by the machine. Carbon dioxide and volatile agents are also displayed graphically. And here is the setup. We have our ventilation tubing, catheter mount, endotracheal tube, the heat and moisture exchanger, the Sidestream gas sample tubing, the water trap, the gas monitor, and the digital and graphical waveform display. This is the heat and moisture exchanger. This is the gas sample tubing. This is the water trap. And this is the gas analyzer. When the patient exhales, gas flows out of the endotracheal tube or laryngeal mask into the heat and moisture exchanger, where part of the expiratory flow is sampled by a clear plastic tube and delivered to the monitor via a water trap. After a 2 or 3 second delay, the monitor displays a graphic waveform of inspiratory and expiratory carbon dioxide and a number indicating the end tidal CO2. Be aware that the Sidestream monitor is connected proximal to the ventilator tubing. If the tubing disconnects, as it may do under general anesthesia, if the patient is breathing spontaneously, a normal CO2 trace will be displayed all the while the patient is breathing room air that does not contain volatile anesthetic. This risks awareness or worse, the patient waking up in the middle of the operation. This is one of the reasons why it is imperative to measure inspired and expired oxygen and set the alarms carefully. There is always a delay in displaying the CO2 trace, and that's 1 to 3 seconds, and this may lag after the airway pressure trace. The heat and moisture exchanger is used in anesthesia and patient transport, but in the ICU, a full humidification system is built into the breathing system, and heat and moisture exchangers are instantly saturated and rendered inoperable. Hence, ICU-specific gas sampling connections are used. This is an example of an ICU end tidal CO2 sampling device developed for Philips monitors. In this situation, the device is located within the breathing system and it's connected directly to the monitor by a wire, so it's a mainstream device. There is no water trap. A similar waveform and number are recorded. Most importantly, when you use mainstream devices, there is no delay with CO2 measurement. Until about 20 years ago, CO2 monitoring in the ICU was rarely performed, and when it was, mainstream devices were used because they rarely get clogged up with secretions and condensed water. However, the problem with those devices is the weight, and they tend to lever the tube out of the mouth. Consequently, in the late 1990s, a new version of Sidestream analysis was developed, and now it's widely used. It's known as Microstream CO2 monitoring. There is an integrated water separation filter at the airway connector that traps condensed water, and that connects to a 1 millimeter diameter microbore tube that maintains laminar flow at a very reasonable 50 mils per minute. The tubing connects to an IR sensor in the Philips device that's called the MCS sensor, Molecular Correlation Spectroscopy sensor. That contains a narrowband IR emitter at a single wavelength, 4.26 micrometers. The matched receiver detects transmitted light intensity, and the processing unit calculates CO2 with the monitor displaying the waveform. Here are the components. The water separation filter connects between the Y or breathing system and the catheter mount. Then the tubing is connected to the CO2 module in the monitoring system. The yellow color of the tubing reflects that it can be used for several days. If you see orange tubing, that is for short-term use, less than 8 hours. The difference reflects the higher moisture tolerance of the extended use tubing. You can pause the video now and look at the list of features and pros and cons of the current technologies. In general, these days we use side-stream carbon dioxide analysis in the operating room because it measures everything, nitrous oxide, volatile agents, etc. But given a choice, I would use mainstream for intubation as the initial delay using Sidestream is really long. Of course, we don't do this. We all use Sidestream. Microstream is the approach of choice in the ICU, but there are other technologies that also use infrared CO2 absorbance in standalone units, but you are unlikely to be using them in your routine practice. Now let's move on to capnography. Capnography refers to the continuous display of the partial pressure of carbon dioxide as a waveform in inspiration and expiration. Mainstream, sidestream, and microstream gas analysis can display waveforms, and this is really useful. The end-tidal CO2 number is also displayed. So let's look at the normal capnograph. It looks like this and has characteristic phases. Phase 1 is the baseline. That represents the beginning of exhalation, where air from the anatomical dead space that contains very little carbon dioxide is exhaled, so the CO2 level is close to zero during this phase. Phase 2 is the expiratory upstroke. It is a transition period where exhalation of dead space air mixes with alveolar air containing CO2. The CO2 concentration rapidly rises during this phase. Phase 3 is the alveolar plateau. This phase represents the exhalation of CO2-rich alveolar gas, so the CO2 concentration reaches a plateau that is ideally relatively flat. The highest point on this plateau is the end tidal CO2 value, representing the maximum CO2 concentration at end exhalation. Following this is phase 0, the inspiratory downstroke. That marks the beginning of inspiration. CO2 concentration rapidly falls back to zero as fresh gas without CO2 is inhaled. It is worth noting that this inspiratory downslope is not perfectly straight, and there are a number of reasons for this. But the best explanation is that the transition from expiration to inspiration is not instantaneous. There is a gap, always, and that results in a brief period during the transition when the sampled gas is a mixture of alveolar and fresh gas, resulting in a gradual decrease of CO2 concentration rather than an abrupt drop. This is the point of maximum CO2 exhalation, and it's known as the end tidal or end expiratory CO2. As an anesthesiologist, I am obsessed with seeing this number because in our practice, when we place an airway into our patient, either a laryngeal mask, an eye gel, or an endotracheal tube, the presence of a good end tidal number and an appropriate capnograph trace is very reassuring to us that the tube or the mask are placed in the correct position. So let's look at some examples vis-a-vis intubation where the capnograph is very helpful. The first scenario is one that we discussed in the previous tutorial. You're called to a cardiac arrest. Sam, who's 72, is intubated by another doctor. Once the tube is in place, the doctor is very confident. There is bilateral chest movement, bilateral breath sounds, and the endotracheal tube mist up to represent water vapor. So the tube is in the lungs, right? Well, maybe, but maybe not. It is an absolute standard of care in this setting to identify, carbon dioxide in expired gas. So let's have a look at the capnograph. It looks like this. What's going on here? Well, this is an esophageal intubation. As I mentioned in the previous tutorial, there is always gas in the stomach and esophagus, and the CO2 content of the stomach is approximately 5%. So when a tube is placed in the esophagus, some CO2 may come out, and that can be measured by the machine, but it rapidly falls to zero. So you need to be very careful of false positives. Remember, no trace, wrong place. The thing that annoys me when I go to cardiac arrest and I know the tube is likely in the esophagus is I'm told, no, the patient has a cardiac arrest, there won't be a CO2 trace. That is absolutely incorrect. If adequate CPR has been applied to the patient, you will see a capnography trace and an end tidal CO2 number. So remember, no trace, wrong place. Let's move on to what would appear to be a relatively straightforward case. Tanya is about to undergo upper abdominal surgery and she is intubated by an anesthesiologist in the operating room. This is the capnograph trace. What do you think is going on here? This is an endobronchial intubation. Although the waveform looks normal, the end tidal CO2 is much lower than usual, and this is the picture you see in an endobronchial intubation, usually of the right mainstem bronchus. The tube is then pulled back 2 centimeters, and this is the trace that's seen. What do you think is going on here? You can see that there is a bifid waveform and that the end tidal CO2 is a little bit lower than you would expect. This is also an endobronchial intubation, and you see this when the tube is a little bit far in, but it isn't fully endobronchial, and gas gets into the tube from the other side via the Murphy's eye or passing around the corner to enter the tip at the opening of the right mainstem bronchus. Just to explain this, this is a normal intubation with a tube placed in the trachea and the cuff inflated. CO2 returns from both lungs equally, and we have a nice normal end tidal CO2 trace. This is the first situation. The tube has been inserted into the right mainstem bronchus, and the end tidal CO2 reflects only the carbon dioxide from the right lung because no gas is coming from the left, hence the very small number. In the second situation, just the tip was in the right main bronchus. The cuff is in the trachea. So gas flows more easily from the right side, but because the left lung can access the tube, gas flows out with some delay, so there is a bifid waveform visible. Early gas from the right, delayed gas from the left. Subsequently, the tube is pulled back 2 centimeters, and voila, we have a normal capnograph. However, 30 minutes later, the trace looks like this. It falls to near zero. What's going on here? This is indicative of a major leak in the breathing system, a disconnection from the mechanical ventilator or accidental extubation. The ET tube is out, you reintubate, and 30 minutes later you see this trace. What's going on here? If the CO2 trace falls suddenly to low values but not zero, it is indicative of a leak within the breathing system proximal to the sensor. There's potentially partial extubation, such as an endotracheal tube in the larynx or a ruptured endotracheal tube cuff. And what you're going to do now is you're going to advance the tube about a centimeter or two, test and inflate the cuff a little bit more and see if the waveform goes back to normal. If it doesn't, the tube needs to come out. The cuff is likely ruptured. Let's review this tutorial. In this tutorial, we discussed monitoring carbon dioxide and I explained Sidestream and Microstream CO2 analysis. We then looked at the normal capnograph and the different phases of the capnograph, and then we looked at the capnograph following intubation. Next time, I'm going to discuss abnormal capnographs and how to interpret them and what to look for if there is no CO2 trace after intubation, but you're convinced that the tube is in the right place. I'll see you then, and I guarantee you'll learn something.